a relaxing summer and get some sort of break and respite from everything that was going on over the last couple of months. Of course, it all hasn't gone away, and we still have to figure a lot of things out. But I do hope everyone had some sort of a break and got some sort of respite from things. And in spite of the weather, you managed to enjoy yourselves for a short while anyway. So as always, I would ask that everybody would put their microphones on mute. It does help with any feedback and things like that. To use the chat function if you want to put in a comment or ask any questions of the panel, and that can be done throughout the webinar tonight. And again, to thank everybody, including all the team in Surgical Affairs, for getting the programme back in action. I think we're going to have a very good programme over the next couple of months with the webinar. We're going to keep them going. They're a very effective way of communicating with our members, fellows, surgeons, trainees, and guests around the country and indeed internationally. And so we're going to keep those things going for everybody. So without any further delay, it just gives me great pleasure to hand over to our president, Professor Ronan O'Connell, who will say a few words at the start, kind of set the scene, I suppose, and then introduce our speakers tonight, which will concentrate on where the clinical programs and their engagement with the HSE are going to help us figure out the resumption of services over the winter, which will indeed be challenging. And then we'll have a Q&A discussion session at the end. And so again, I'd encourage you to send in your comments or any questions. So President, over to you.
Thank you, Kieran, and good evening all, and welcome back to the weekly webinar series. It seems such a short time and yet such a long time since we've had the pleasure of joining with you all at the middle of, so like Kieran, I hope you've had some time to relax and to have a nice staycation for at least some good weather in Ireland. As Kieran has said, we have put together, together with Laura Vianney, our Vice President, and our colleagues in Surgical Affairs, a very interesting program, I hope, of weekly webinars over the next 10 to 12 weeks. And if there are particular aspects of things that you would like to be addressed or suggestions for topics, please do not hesitate to send us an email, and we will see. Nothing is set in stone, and we can be a little bit flexible with the order of things. I think we've all got very used now to Microsoft Teams and Zoom, and in that regard, great credit to Michael, Karen and colleagues in Galway for the FRERE Symposium, which went ahead. And I have to say I was pleasantly surprised at how well it worked, though we all do miss the social aspects and the collegiality that comes from meeting together. I think we have, in the eye of the storm to a degree. We can see the numbers of cases are increasing considerably, up 300 yesterday. I don't know what they are today. But if that rise continues, then undoubtedly it's going to cause very great difficulties for our public hospitals. You may be aware of some of the correspondence that I, as president, along with the president of RCPI and the president of the College of Anesthesiologists, have had with the minister and HSE and Department of Health with regard to the importance of maintaining continuity of care and training opportunities if the department decides to outsource elective work or scheduled work to the private sector. And I think this is very important because the training numbers, as you will hear, and the numbers of elective cases are really still quite reduced. Not as bad as they were in April, May, and June, but we're still way behind where we need to be. So, Great credit to our colleagues who are involved in the clinical programs, Debbie McNamara, David Moore and Paddy Kenny and Michael Walsh, all of whom are going to speak to you this evening about the clinical programs in general surgery, in trauma and orthopedics and ENT, head and neck. So with that introduction, I'd like to ask Debbie McNamara to lead off on general surgery. Thanks, Debbie.
Thank you very much, President. Erica has some slides. Thank you. So I'd like to cover 3 areas this evening. Next slide, please. As you say, there was a very good discussion at the FREIR recently, so I don't wish to repeat those aspects, but there are a few aspects of current surgical activity that I would like to bring to the attention of members and fellows, and in particular some of the things we've learned from operating in the current COVID prevalent era and what the next steps are for surgery over the coming months, insofar as they can be predicted. Next slide, please. So there's been a dramatic reduction in surgical activity in the year to date. This data is taken from NICWIS with the support of Gerard Kelleher. Emergency surgery is down 30% and elective or scheduled surgery is down at least twice that at 63%. And at the same time, our waiting lists have increased by 36%. And worryingly, there is also a reduction in the number of referrals from primary care into our usual lists. So we are missing, if you like, 10,000 referrals compared to last year, and it's very likely that that represents unmet need in the community. Certainly our general practice colleagues are expressing concern in the public domain about the ability of hospitals to cope with the numbers of patients that require care. Next slide, please. You will all be familiar with this waiting list graphic where the green represents the shortest waiting patients and the red represents patients who are waiting more than 48 months. And you can see that spike in the last few months that has arisen as a result of the lockdown phase where no surgical activity took place and where numbers were greatly reduced just down to urgent operations. And even in the month or 2 that we have been able to get services up and running again, we have made some significant progress, but nonetheless of concern, the cases that are most disadvantaged so far are the patients who are waiting the longest. And there's been a very substantial 70% growth in patients who are waiting prolonged periods of time for surgical treatment. Next slide, please. As we all know, outsourcing models generally favor less complex procedures. During the lockdown period, there were some complex operations performed in a small number of private hospitals, and some public hospitals managed to continue performing complex surgery. But in general, outsourcing models are best suited to less complex procedures. And so it's very important that we not only identify pathways for less complex procedures, but most especially for the more complex, longer waiting population, who of course are long waiting because by and large they are not suitable for outsourcing. Next slide, please. And even based on our current activity, surgical activity in Ireland needs to double if we're to even get to the levels that historically are the norm. And that's before we begin to replace any of the activity that needs to be met, the needs from those waiting lists. Next slide, please. So how do we unlock that surgical capacity? And as surgeons, we are facing a number of impediments every day when we try to do our operating lists, when we're trying to admit patients. How can we begin to unlock the surgical capacity in the country? Next slide, please. And perhaps really what we should be asking is, how do we move beyond the fear and the paralysis that COVID has induced to actually trying to, in a very measured, evidence-based way, resume surgical activity? Next slide, please. So if we look at the pathways of care that are possible for our patients, obviously there remains the need for emergency pathways of care as shown in the COVID pathway box there, but scheduled surgery pathways are still required, and they will require ring-fenced beds and so-called clean pathways where patients are screened for COVID where they are only exposed to other patients who've been screened for COVID, and where they have care in a very protected environment to ensure their safety. Next slide. We have learned a great deal about operating in an environment in which COVID is prevalent, and it is likely over the next 2 years that COVID will remain prevalent. So this is part of what we need to deal with in our practice routinely. Next slide. In this large Irish series of 3,800 cases collected with the help of very many colleagues who are all acknowledged on the bottom of the slide, has demonstrated to us that the mortality postoperatively is highest for patients who do not have preoperative screening, and that is especially the case when community prevalence is high. So you can see the green bar there. The mortality is most common in patients who've had no screening at all. And the other forms of screening operate similarly with some advantages, and on average, the questionnaire and the swab works best when community prevalence is high. Next slide, please. So we know quite a lot that we didn't know when COVID started. We know that every surgical patient should be screened when they present for unscheduled care. We know that patients coming for scheduled care also benefit from screening. We do know that COVID is uncommon in patients who undergo surgery, and the overall incidence in the Irish population seems to be around 1.3% of patients who've had an operation and become COVID positive postoperatively or are identified to be COVID positive postoperatively. We also know that outcomes are best for patients who are on a non-COVID pathway, that ring-fenced pathway that I referred to. Patients on a non-COVID pathway have a 0.6% chance of being diagnosed with COVID in the week after their operation, compared to 2.3% for those not on that separate pathway. And the risk for the patients of postoperative mortality is 0.1% in a COVID prevalent environment for patients cared for on a non-COVID pathway. Next slide, please. I mentioned that the best outcomes in that COVID prevalent environment was from the combination of a questionnaire and a PCR swab in which COVID is not detected. Swabs become less accurate and less useful in an environment where COVID is not prevalent, however. And so in areas of the country where COVID is less prevalent, it may be the case that some moderation in the guidance would be acceptable. And that's been the subject of some work recently that I'm going to share with you now. Next slide, please. So the HSE have worked with the clinical program in surgery, the clinical program in trauma and orthopedics, and our anesthesiology colleagues, as well as the health surveillance centre. And they accept that there is now sufficient data that in a low prevalence environment, if we can create a pathway that minimizes exposure risk for patients by promoting self-isolation in the 2 weeks before operation, and by use of a structured risk assessment questionnaire, that quite effectively mitigates the risk for patients. And this is the case in a low prevalence environment for COVID. Next slide, please. Now, of course, that brings us to what is a low prevalence of COVID environment. And that is something that has been redefined lately. What we now have that we did not have at the beginning is really reliable epidemiological data from the Health Protection Surveillance Centre. And I would encourage you, if you have an interest in this, to look at their website. They publish reports daily, Monday to Friday. Next slide, please. And so they can demonstrate, and this map comes from their website, they demonstrate the overall incidence, and you can see that the COVID prevalence around the country has been variable in terms of the incidence of the disease and also in terms of the current prevalence of the disease. What we need to move towards is a more nuanced approach that doesn't just look at one national figure and apply one national standard, but that does allow some local variation to take place in a structured and safe way. Next slide, please. So one of the particularly useful pieces of information from this report is the rolling 14-day data, and this is available on a national basis. So, for example, you can see on this report at the bottom, it's 31.9. And the definitions that we use on that rolling 14-day data is that if the prevalence is less than 20 per 100,000 over the preceding 14 days, we consider that to be a low prevalence environment. And if it is greater than 20 per 100,000, then that is defined as a high prevalence environment. Next slide, please. Now, I know that that's perhaps a very simplistic view for the surgeons that maybe weren't as interested in epidemiology when we were in university, but I think this is quite an interesting table. This table shows us the variation by community healthcare organization. So this is by HSE region, if you like, and you can see that although the national incidence on a rolling 14-day basis in this graphic, which ended at midnight on the 6th of September, the national number is 35 per 100,000, but you can see that area 4, for example, has a really low incidence of 9.3 per 100,000, with area 7 having a much higher incidence of 63 per 100,000. And we need to enable local hospitals to take a nuanced approach based on the risk factor that prevails in their area. Next slide. This data is available by county and as well as by health area. So this can be a very useful source of information. It is circulated daily, Monday to Friday, to all lead clinical directors and to all hospital groups. It's freely cascading through the HSE system, so it is widely available. And it enables our clinical leaders to develop more nuanced evaluation of risk and trends, not only by hospital side, but also by the patient's community and their basic risk of carrying COVID, so that we can respond in a more appropriate fashion. Next slide, please. Using this information, the scheduled care guidance enables local hospitals to respond appropriately. And at present, for areas with less than 20 cases per 100,000 over 14 days, PCR swabs are not mandatory if the local hospital develops a protocol that does not require that. Whereas in higher prevalence area, in general, the combination of a swab and a questionnaire is recommended. Next slide, please. At the same time, we are trying to encourage development of ambulatory surgical pathways that will enable patients to be out of hospital as quickly as possible. This work is carrying on in all of the specialties who work with the national clinical programs, and I've no doubt it's also happening with our colleagues in trauma and orthopedics. Our group recently published a meta-analysis looking at factors which prolong length of stay following lap chole, and as a response to this, we've updated the clinical guidance around the care pathway for day case lap chole. That care pathway is available on the RCSI website for consultation, and we look forward to any feedback on that pathway. Next slide, please. So that's what's happening in the area of scheduled surgery and getting clarity around those pathways, and also having a more nuanced approach to risk assessment so that infection prevention and control is enabling practice as opposed to acting as a barrier to practice. More recently, we have begun to work in the area of unscheduled surgery, and my colleague on the clinical program, Professor Paul Ridgway, is participating in a group involved in looking at unscheduled surgery and how the acute floor and emergency department should respond in the COVID environment. Professor Ridgway is going to particularly look at the patients who require urgent surgery, and that is proving to be difficult in some hospitals, with delays in accessing urgent surgery sometimes happening for patients because of delays in COVID testing. And they're trying to come up with some guidance to try and help hospitals manage that situation in an evidence-based way. Next slide, please. As ever, I'd like to thank my colleagues on the clinical program and my colleagues in surgical affairs for their assistance with this work, and I'm happy to take any questions. Thank you very much.
Thank you, Debbie. And as always, very clear. And I'm looking to see if anybody has their hands up. If you could use your hands up on the Microsoft Teams to ask any questions. So, Debbie, can I ask, is that publication that you refer to, is that now available on our website? Is that
Yes, so that's a HSE publication. It is available on the website. And in fact, I see the PARC has put a link in the chat function for anyone participating tonight who wants to access that directly. It's in the COVID section with information for surgeons on the RCSI website.
And that's only recently released?
So that's released in its final version in August. We had prior versions up for consultation. There has been some change over the last, just in the last iteration, just to accommodate the ability for there to be local variation, because it was really felt that one size is not fitting all in relation to the environment for COVID nationally. And now that we have better information, that will enable local hospitals to take greater control of the pathway that's most appropriate for their risk pathway. So I think it's something to be welcomed. That we are devolving that ability to the local environment to respond to the needs of their community.
But it does strike me that most of our Model 4 hospitals are in areas where really we need to be taking not only the questionnaire, but also the swab, and because we're all in high prevalence environments.
Sure. I suppose the one factor in Model 4 hospitals is that many of most of our Model 4 hospitals are cancer centres, and patients who have cancer do represent a specific subset. NCCP have also published guidance on this, which they are due to review later this week. So the cancer patient and the patient who, by virtue of their disease, is very high risk, does need to be considered specifically. But if you take the example, for example, of Sligo, a very busy Model 3 hospital, such hospitals are in a very low prevalence area and perhaps can get on with a lot of activity without being delayed by COVID swabbing.
Okay, are there any other questions? No, Debbie, I think you've got off very lightly this evening, but thank you as always.
Thank you very much.
Okay, and can I now ask David Moore to join us and to give us an update on trauma and orthopedics? David.
Thank you, Ronan. Erica, thank you very much. So this is just an update on the trauma and orthopedic clinical program and where we are at the moment. Next slide, please. So I'm really going to talk about two areas in particular. One on the trauma side is the trauma assessment clinics. I'm not going to go into what they are. We had a webinar on it, but what they do is they reduce the amount of patients who we refer to fracture clinics, and that has a knock-on effect of not only reducing the size of the ordinary fracture clinic of new patients, but there are no review appointments subsequently either. So it's a very efficient way of managing minor injuries, which a huge amount of the fractures we see are. One of the problems we had was getting resources to be rolled out nationally to provide the personnel to run the trauma assessment clinics. Next slide, please. And what we found during COVID is that if you look at the encircled area 2/3 of the way down on the left, a full TAC clinic was possible to be rolled out in all the green boxes. So almost nationally, we were able to roll out these because they all require, they're all virtual clinics. There's no face-to-face activity going on. And we had personnel available. One of the problems previously was we didn't have physiotherapists or nurses or doctors available. When COVID struck, obviously people were deployed, they were taken away from other duties. And that facilitated the pretty much national rollout of the TAC clinics. Clearly, we had a concern that this was going to be unwound again now, that these good practices were not any longer going to be able to be maintained because people would go back to their normal jobs. So we've been agitating with the HSE to provide funding for the personnel required to run these TAC clinics. And today we heard, and we got an agreement in principle, that now 600,000 euro has been allocated to provide staff for these clinics nationally. And that really will make an enormous difference to the continued safe practice of fracture clinics and reducing the numbers that attend. So while there's still some paperwork to be done, that's 600,000 euro that we didn't have available for those clinics yesterday. Next slide, please. So the areas I'm just going to focus on now are the perennial ones of waiting lists, both for outpatients, next slide please, and for surgery. We have had, like all other specialties, we have had escalating waiting lists that have just been getting bigger and bigger prior to COVID. And as Debbie has already shown, there's been a jump in patients who are waiting. We didn't really see it during COVID because the patients weren't attending the GPs, but now they are, and our numbers are going up. We now have record waiting lists. We have almost 78,000 in orthopedics waiting to be seen nationally. Next slide, please. One of the initiatives we have used very effectively in the past is our MSK initiative, whereby physiotherapists in most of the acute hospitals triage patients, see them, and as you can see here, have taken 150,000 patients off our waiting lists since 2013. You can imagine what our waiting list would be now on top of the 78,000 if this successful project hadn't been there. What we've been trying to do is come up with new ways of dealing with patients and preventing them ideally from even reaching the acute hospitals. And we've been arguing and appealing to the HSE for some time to allow us set up what we call interface clinics. And what those are patients who are referred by GPs with musculoskeletal pathology, and this is in conjunction with our rheumatology colleagues. The MSK initiative, the orthopedic groups, the orthopedic patients are about 85% of the total, and the rheumatology patients about 15%. What is happening now is that we wanted to have interface clinics whereby when the GP sees the patient, they may actually be able to get a physiotherapy triage in the community and actually stop them at source, stop them getting onto our hospital waiting lists. That would take some training up of physiotherapists and then them being deployed into the community. For 2 years, we've been agitating and pleading and asking for resources. And today we got news that, again, there's an agreement in principle that over the next 2 years, 21 and 22, we will be able to employ just over 36 full-time equivalent physiotherapists at a cost of 2.4 million. And they will initially work in the acute hospital, where they'll be trained up by the current MSK physiotherapists, and then gradually rolled out to interface clinics in the community. And then hopefully the knock-on effect will be that we prevent a huge number of patients languishing on our waiting lists in hospital, and they can be managed in the community. The delivery of that, because it was a long, arduous task to get the paperwork through for these projects, both the TAC one, the two of them together come to about 3 million that we were informed today we have in principle, is really due to the diligence and perseverance of Catherine Farrell, our program manager, and Niamh Keane, who's our project manager. They have been hounding and encouraging the HSE, and now the fruits of their work primarily have borne, well, we're happy to have this funding available over the next 2 years. And that hopefully will make a big dent in our waiting list. Clearly, a consequence of that, however, is that we're going to have increased surgical waiting lists, and I'll come to that in a few moments. Next slide, please. One of the projects we put into the, at the top here, as you can see, 73,000 patients waiting over, this is nationally, over 30,000 of those have been waiting more than 12 months. The slide you're looking at now is really the waiting, patients waiting in the Leinster region is probably the best way of putting it. And we recently had meetings, following a meeting with the minister, the new Minister for Health. We've had meetings with the HSE combined with the NTPF. And we put in a proposal to start dealing with these huge numbers of outpatients. And can we go to the next slide, please? This, for those of you who aren't familiar with it, is the conference centre in City West. There are 300 beds there that have not been used during the COVID crisis. We visited there about 6-8 weeks ago and have put in a proposal for part of this area to be turned into outpatient clinics. And this looks like it's about to be delivered on by the NTPF. And it will initially roll out with the Children's Health Group and Dublin Midlands Group, arranging to see long waiting patients there funded by the NTPF. We're also introducing a new, this facility is currently, is now being used for outpatients, for some other children's outpatients and for glaucoma. And it is certainly, you know, every specialty should be potentially looking at it as a resource where patients can be seen. Certainly in orthopedics, we have difficulties in the hospital with waiting areas for around our clinics to facilitate proper social distancing, and the same applies in our X-ray departments. So to have this space available, and clearly this can be copied around the country in currently inactive vacant conference centres that exist in many of the big towns. At the same time as this, with the principle of trying to avoid face-to-face appointments as much as possible. Next slide, please. We are about to introduce a new way of vetting patients called active clinical triage. And this new ACT regime would involve and again, initially for the NTPF funded long waiting patients, where the surgeon will actually call a patient, decide on the phone, do they really need to be seen? Maybe the figures from Scotland tell us that maybe we'll be able to dismanage 20% of the patients on the phone, and then the rest we can direct appropriate investigations and then give them an appointment to come along to City West to be seen for their face-to-face opinion, and then to be dealt with really hopefully as a one-stop shop. We'll have injection facilities available. If necessary, patients can be put on a waiting list for surgery, or they can be discharged. So this is a new system that most of the groundwork has been done on, and really we're just now in the process of asking surgeons to see the patients and to actually select appropriate patients to be seen. We would hope that ultimately this system of active clinical triage, if we can eventually get some control over our waiting lists, could be applied to new referrals, that as soon as a referral comes in, once people have protected time to do this, that they can then contact the patients and in a very efficient way, hopefully, deal with them at source once they've been referred from GPs. Next slide. So the problem with any of these efficiencies, as we've learned from the MSK initiative before, is that we generate large numbers of patients waiting for surgery. Last slide, please. And there are a number of ways of which surgery can be delivered. We've spoken before, and I'm not going to enlarge on them really, but about extended working extending the working day and weekend working. I know that the NTPF are very happy and very keen to fund initiatives presented to them by individual hospitals or by hospital groups. And I would encourage surgeons not to wait for someone to organise it for them, but literally to call up the NTPF. We'll give you the names and the emails of the people to contact. And they are very keen, and the Minister has directed them to make funds available for any initiatives that will reduce the waiting list. Clearly, there are problems in the acute hospitals with accessing with ring-fence beds, and that's not going to do anything except deteriorate if we have an increase in the number of patients being admitted with COVID. One thing that we've done in one of our hospitals is we have arranged an outpost or embassy theatre that we will have 1 day a week in one of the private hospitals. And I think that that's something that if there's capacity available around the country in neighbouring private hospitals, that people should be encouraged as much as possible to see could they set that up on an ongoing basis. And again, the NTPF have agreed to fund that once the business case is put to them. So that's all I've got to say. There are just some of the, there's just one other thing. We also have an initiative going on with a multidisciplinary group for a fracture liaison service. One of the big issues most people would be aware of in orthopedics are hip fractures, but that's just one of the fragility fractures that we deal with due to osteoporosis. So with our colleagues in endocrinology, rheumatology, age-related healthcare, physiotherapy, and orthopedics and rheumatology, we have set up a multidisciplinary working group, and a project manager commenced in August to try and identify patients who have fragility fractures, and then ideally to commence them on treatment to try and prevent them developing hip fractures as time goes on. And that is pretty much a summary of our update since our last one. Thank you.
David, thank you very much for your presentation. Maybe people could mute their microphones, stop the echo. Thanks. And I have to say a great tribute to you and Paddy Kenny and others in the program, CNO program, in achieving so much. It does strike one that COVID has had the advantage of making accelerated decision making, and that funds are being made available that would have been very difficult to release in the ordinary year. And I think everybody now realizes in the Department of Health and HSE that if you can move out of the acute hospitals and provide care in the community or in a halfway house between the community and the acute hospitals, so much the better. Can I just ask you a couple of things? Firstly, about telephone triage. We don't really get any training in how to do this. And are there any particular aspects of it that you would like to emphasize for the people listening in who may have to do this?
Well, I certainly wouldn't set myself up as an expert on it, and I'm aware of lots of shortcomings and risks. I think it's very important that patients be notified in advance. There are lots of training courses available for this now, but I think patients have to be notified in advance. You have to get consent. You have to let them know that you don't have full information available to you, and that even after a conversation, you can't examine the patient. So I think certainly in orthopedics, it has a limited role. It does have a role certainly in new patients, but I think it does have a role for post-op patients or for follow-up patients where you're familiar with them. But other specialties would have maybe a varying view on that. But I know that it has a limited role for orthopedics.
We have Dr. Anjum, or Mr. Anjum, have you got a question? Your hand is up. Naveed? If you're trying to ask, you may be muted. Okay, we'll carry on. David, what about the IT facilities in the City West consultation? I mean, can you access electronic medical records, or do you bring the old hospital records out with you for these consultations?
Well, the idea here is that these are all new patients, new referrals, so they don't have existing records. They're new patients, the same as patients, I suppose, who are referred to private practice for NTPF work. The IT, I think what we're trying to do is stay away from IT, because most hospitals have different IT systems, they have different PAS systems, different IPINs. What we will have available is NIMS, so that we can see X-rays, and we will have an X-ray facility there. Also, we will have a truck that can do 50 X-rays a day. As you will understand, Ronan, we're fairly simple beasts. We just want a piece of paper that we can record our findings, and a facility to look at the pictures in the form of X-rays. And that will allow us to deal with the vast majority of patients who would be attending.
I'm glad, David, you described orthopedic surgeons as simple beasts. I never would have described you as simple, but there you are. Then what about backfilling in the base hospital when you go out to these facilities?
Yeah, so certainly this is not, we're not trying to take away. I mean, this is going to be done, and people will have to agree the times they can do it. And this will be done the same as if you were in your private office, or if you were on holidays, or you took a day off. We certainly don't want to compete with people's normal commitments to the health service. This would be additional work.
And with regard to that, I'm sure many people will do it pro bono, but if you're extending the working day, how are hospital groups going to manage the staffing for that?
Well, not for a moment would we expect that people would do this pro bono. This is going to be, an extra work, and it will not be, not for a moment would I suggest that people do it for nothing. I think they should be paid for their work. The amounts we need, and this will depend on each of the hospitals, and certainly the hospitals want to deal with the patients. They will be factoring into the costs and the business case for each setup going into the NTPF a clerical cost for people from the base hospital.
Thank you, David. Are there any questions then? I just have one hand up, but Naveed doesn't seem to be coming online. Well, then we might move on to Michael Walsh, who was the lead for, or is the lead for ENT head and neck, and they produced a very substantive document on the pathways for ENT and head and neck surgery. Michael, I'd be very pleased if you could take the floor and let us know about progress in ENT head and neck surgery during COVID, and in now beginning to deal with the very big waiting list.
Thank you, Ronan. Could I have the first slide there, please, Erica? Thank you. I must say I'm very impressed by the achievements of trauma and orthopedics. Makes me somewhat jealous. On the next slide, please. Just before lockdown, a group of our colleagues got together to formulate some guidelines on the management of emergency cases. Next slide, please. This was coordinated under our colleague Mary Bresnahan. In the early phases of this pandemic, there was some publications in prestigious journals which were somewhat alarmist. And because of this, the next slide, please, Erica. We, as a specialty group, decided that we'd only make recommendations based on multidisciplinary care or peer-reviewed journals from multi-centres. And a number of our colleagues contributed to this, including Peter Lacey, Paul Lennon, James O'Neill, and John Russell. Next slide, please. We also published recommendations regarding time-sensitive surgery, as with all the other surgical groups in the NCPS. Next slide, please. And as we have come out of the shutdown phase, we've put forward recommendations on resumption of activity and procedures being performed in the outpatients, which we'll discuss briefly later on. Next slide, please. So we published our model of care for our specialty in February 19. Next slide, Erica. And this was to address the situation pre-COVID of huge waiting lists for our specialty, secondly only 2 orthopedics. And next slide, please, Erica. And the long waiting lists for inpatient and day surgery. Next slide, please. These are the projections carried out by Jerry Kelleher at what would happen if no initiatives occurred to deal with this problem. Next slide, please. Our strategies were based on, first of all, consultant manpower expansion. Services are provided from 13 major units throughout the country, plus the 3 paediatric hospitals in Dublin. And in addition, there are 10 satellite units for outpatient services are provided throughout the country. Next slide, please. If you look at this graph here, this bar graph, it shows on the left, the majority of activity occurs in Model 4 hospitals with very little usage of the Model 3 and 2 hospitals. So we've recommended some form of selected elective surgery will be expanded into these hospitals to deal with our waiting list problems. Next slide, please. Next slide, thank you. So our strategy is based on, as I said, consultant expansion, but also use, as the orthopedics have done, of physiotherapists. We use audiologists, physiotherapists, and speech therapists for GP direct referral to triage patients. This is obviously done under the governance of consultants. Next slide, please. A pillar of this is an electronic referral system, which we haven't established yet, which is bespoke for our specialty, and also the instigation of a GP educational program to have a cohort of GPs working in the community with special skills and knowledge of care pathways for our specialty. And Professor Camilla Carroll has been rolling out this over the last 2 years. Next slide, please. So this is a graph showing for surgery in general what happened in the early phases of the pandemic with the impact on the waiting lists. Next slide, please. We can see a similar pattern as Debbie showed in her slide, with a peak because of the shutdown, and interestingly a significant decrease in the number of referrals. So there's a large cohort of patients out there who have not been seen yet, which will probably turn into emergency situations down the road, high percentage of cases. Next slide, please. And pre-COVID, our outpatient problems were out of control, and now at this phase, they're extremely out of control. So the strategies we have recommended really will have to be enacted if we're to deal with this problem in any way. Next slide, please. So we published a document, the resumption of outpatient activity as we came out of COVID. Next slide, please. And basically what the traditional way of delivering outpatient service is not viable anymore. It wasn't fit for purpose pre-COVID, and it's certainly not now, because the time to see a patient is increased significantly because of scheduled slots required, because of social distancing and use of PPE in the outpatients. So other strategies have to be adapted and utilised and funded and supported long term. Next slide, please. In the initial phases of coming out, there were problems, and still are problems, because of hospital infrastructure. A lot of our hospitals are old, small spaces allocated to ENT departments, problems with ventilation, problems getting our theatre sessions back, anaesthetic cover, and access to diagnostics have been major problems in resuming activity. Next slide, please. We just discussed virtual clinics. They've been used by all the ENT departments, and they've been proven to be beneficial in publications by our orthopedics, urology, and general surgery colleagues. However, these telephone virtual clinics need to be supported by the administration They need to be recorded as activity, outpatient activity. They're very useful for triaging patients, for investigations, for review of post-ops and returns. Obviously, a significant number of patients have to have a face-to-face consultation still. Next slide, please. One of the trainees in the Ioneer looked at this and pointed out the problems that you need a confidential space for these consultations. They can't be moved around from room to room in the outpatients when you're speaking to patients confidentially. Next slide, please. And as David pointed out, they need to be contacted with the radiology and pathology so that you can discuss the results with the patient and you're not making 2 and 3 telephone consultations for one consultation. Next slide, please. Now, the HSE have promoted the use of telehealth, this attend anywhere. Now, the rollout of this has been very variable in the hospitals as far as I can see. Next slide, please. These systems will be extremely useful with validated questionnaires for triaging patients for investigations and selecting patients for surgery and attending at face-to-face consultations. Next slide, please. And there are apps out there which can be adapted. This one is used for hearing screening in children and adults and has been validated and recognised by the Australian government. So strategies like this will have to be adopted if we're to deal with our especially long-term waiters. Next slide, please. These virtual clinics are useful for many areas of most of the subspecialty areas. Obviously, there are a significant cohort of patients that will have to attend, but the object will be minimize the attendance to a minimum by having all these investigations carried out appropriately before attendance. And hopefully the virtual clinics will aid in this, if nothing else. Next slide, please. So our recommendations were generic recommendations in relation to social distances, which would apply to all specialties, and specific recommendations in relation to procedures we carry out in the outpatients. Next slide, please. We carry out a large number of outpatient procedures in otolaryngology. Most of these are not coded, so they don't appear in the HYPE data, which is a problem that will have to be addressed. Now, some of these procedures are definitely aerosol generation and at risk, for example, changing tracheostomy tubes or putting in a valve prosthesis in a laryngectomy patients. The one that was of contention was the fiber optic nasendoscopy. Seen being performed here. Next slide, please. Because of the concerns of aerosol generation in relation to this procedure and risks, and as I said, because of a lot of alarmist publications in the early phases, a subcommittee was formed under the chairmanship of our colleague, Professor Patrick Sheehan, and included some members from AMRIC, Professor Martin Cormack and Dr. Deirdre O'Brien and Dr. Joan O'Gorman, which were extremely helpful in getting recommendations regarding this procedure. Next slide. So the concerns initially were because in China, there were a high number of otolaryngologists were very sick and died because of COVID exposure. And our colleague, Dr. Halrani, graduate of the college, was one of the first medical people to die in the UK from COVID exposure. So there are certainly definite concerns about these procedures. Next slide, please. Nasendoscopy basically is carried out about 2 out of 3 patients who attend an ENT outpatient. So there's huge volumes of this. So any slowdown on this procedure has a major impact on our ability to provide outpatient service. Next slide, please. The question was, is it aerosol generation and what is the risk? And having looked at the literature and studies available, we can say that it's not an aerosol generation procedure, but there is potential for droplet production because it can induce sneezing and coughing. So next slide, please. The risk stratification for the procedures is outlined here, what evidence was available at the time. And even though there was low level of evidence for it being an aerosol generation procedure, the recommendations were in the initial phases that you needed nearly an hour between each case to decontaminate the room, which is totally impractical for providing ongoing service. Next slide, please. So based on our committee recommendations, we decided to stratify the patients into high risk and standard risk. that the procedure should be carried out with a monitor and recording system, video stack system, to allow for distancing between the patient and the examiner, and that you didn't require full decontamination of the area after each procedure unless the patient had excessive sneezing or coughing. And you should be able to turn around the patient really within 10 minutes and not an hour. Now, the problem we've had, even though we've had great help from the AMRIC committee, this information doesn't have seeped out into the individual hospitals at frontline level, and there are still infection control people and nurses telling the surgeons, consultants and trainees that they have to wait outside the room for half an hour or more while they decontaminate the room. And unfortunately, this has had will have a huge impact on our ability to deliver service. Next slide, please. Simple measures like providing ventilation can aid in this. This is the outpatients at the moment where simple corrugated vents were put in and Perspex screens to help the patient. These are low cost. And there is a problem, as I said, because of infrastructure in some of our older hospitals, especially where we carry out satellite clinics where they're not equipped appropriately at all. And this will have to be addressed if we're to address the outpatient problem. Next slide, please. Based on a survey carried out by an audit by our colleague Maureen McCall-Walsh, we found that only 2 departments in the whole of the 13 had adequate equipment to provide this service. So based on this, the NCPS, with the help of Pádraig Kelly, put together a business plan which we forwarded to the acute hospital services to fund these scopes for all the hospital units as a package. Unfortunately, we've heard nothing back officially. Some of the hospitals have received the appropriate equipment, some have received none. So we're in a very variable position across the country regarding this situation at the moment. I think it highlights one of the issues in dealing with the HSE, that the central edicts don't appear to filter down to the frontline level in every hospital. Next slide, please. Ancillary professionals are a huge importance to our specialty, like every other specialty. In audiology is a core area. We've had problems with that because we're in enclosed environments with poor ventilation, and we've had a very low manpower level in audiologists. Thankfully, I think we will be getting funding to expand the number of audiologists in the country for each acute hospital service, and I hope that will come through before Christmas. Next slide, please. So, as I said, GP education is a fundamental pillar of our strategy for our model of care. As I said, Professor Camilla Carroll has been rolling out an educational program for the last 2 years, and this academic term certificate will be awarded to general practitioners and audiologists who attend the course run under the auspices of the College of Surgeons with the School of Nursing. And this is hopefully will be a huge advantage to us down the road when we get these GPs out in the community, triaging the patients and carrying out some minor procedures. Next slide, please. This is the rollout of the program, which, as I said, this is Professor Tom O'Connor and Professor Nash Patil from the Institute of Otolaryngology when we instituted this program at the rollout of our model of care. Next slide, please. Thankfully, our training program has got back on stack. We had our first simulator teaching program in rhinology surgery last week under the directorship of our colleague Mona Thornton. It was greatly appreciated the help of Clive Lee and Oscar Trainer in this. We actually run 7 simulated courses in our specialty in the simulation centre in the college, which is a fantastic resource to have, and we hope to have these ongoing now during this COVID times. Next slide, please. We've had scheduled webinars with the Irish College of General Practitioners, which is very interesting. And one of the things the GPs highlighted was importance of contact with consultants. And what they suggested was that if they could have a hotline where they could speak to a consultant maybe once a week regarding patient problems they may have, rather than having to go through hospital switches, which take forever for them to get to an outpatient. And this is something that the HSE are looking at in relation to our specialty. Next slide, please. The barriers to resumption of activity, I'll finish on this really, there has been not so much in the laboratory end of the PCR testing, but the logistics. Some of the smears are sent from day wards, some of them are sent from admission units, and there's a huge variation when these tests are sent. And especially for surgeons who have lists on Monday and Tuesday, they often come in and find out the patient has been smeared and the case has to be cancelled. And this area has to be tightened up. We've also, as I said, variation in the interpretation of the infection control guidelines, availability of equipment, as we suggested, variation of theatre sessions return, and we have a major problem in paediatric otolaryngology that has existed pre-COVID, but it has got worse, and we need a major initiative from the HSE to address this problem. It will not be satisfied by the opening of the new Children's Hospital. Thank you for your time.
Thank you, Michael, very much. And again, congratulations to you and your colleagues for the amount of work that you've done on the clinical programs and the recent recommendations. It does strike me, however, that you have identified all of the shortcomings that one knew about, but these now represent real blockages to resumption of anything approaching normal services. Even with 10 minutes downtime between nasoendoscopy rooms, one suspects that you're going to find that you're not going to be able to approach 100% of the pre-COVID workload. So how are you going to address this shortcoming in the public hospitals in the context of a huge waiting list that was pre-existing?
Well, Roland, obviously we're going to need some investment, and I must admire the orthopedic surgeons, the investment they have had. We have to have investment in the equipment, obviously, but also utilising the Model 2 and 3 hospitals. We've been speaking about that for a number of years. They're totally underutilised. They're available there. Provided the equipment is there, we could outsource a lot of our Model 4 work to those hospitals. That is the only solution I can see. And I agree with David regarding the resource out in places like City West. It's quite mind-boggling when you walk out there and you see all these massive number of empty beds lying there not being utilised. And facilities like that will have to be utilised. The manpower is an issue. We do have a low consultant base, but gradually it's been beginning to expand. And in the last month or so, we've had 3 consultant appointments. So hopefully that will continue.
You mentioned the hotline for general practitioners were looking for. I mean, we started that in general surgery as a COVID initiative, and Ken Mealy, I think, was to the fore in that. But we gradually found that it wasn't being used, and although it was a nice headline to have, that really, while the GP said it was a great thing, it was not being used. I don't know what your sense is of the value of a hotline from a GP to an ENT surgeon.
I think, Roland, that might have been in the early phases of COVID when the GPs were very concerned about what services were being provided and what patients they should send in. So I think it was probably more useful at that phase. I would agree, long term, it's probably not practical when you have the virtual telephone clinics and if you have the telehealth systems in place that you need a hotline.
This is a question for all 3 of our contributors. Do you think that going forward that every new patient who is referred, that once you get the referral letter, rather than triaging it as we used to in the past, that you should actually arrange a telephone consultation with the patient? Maybe Debbie McNamara might come in first, then David, then Michael.
And thanks, Ronan. I think certainly the new patients, there is some benefit in that face-to-face contact. Where I think more nuanced triage is really useful is the patient who clearly needs an investigation so that a decision can be made at their consultation. So the patient who clearly meets the criteria for a colonoscopy, for example, or the patient who clearly needs an X-ray, if we can triage cases like that so that the patient attends with the investigation so that they're coming to the hospital on fewer occasions. I do have some concerns about not seeing new patients face to face, particularly if we're making decisions about operations on patients in the medical legal climate in which we all work, developing a relationship with the patient and really, I think experienced consultants rapidly develop a sense of where the trouble lies when they meet a person. And so I think, yes, we can do better. And a lot of our specialties have moved towards the sort of protocol that David Moore so nicely outlined this evening.
David, should you have the X-ray before it's determined that you need one, or should you do a phone consultation first?
I think there's this would have to be kind of a bespoke arrangement. Some patients need X-rays, some don't. Obviously, for the majority of ours, they do. One of the problems is access. So our X-rays in some hospitals now are rationed because of social distancing problems. That's why we'd have to get the truck available to give us X-rays. I think the most important thing to be clear on is that all this takes resources. It's easy to say every patient should be telephoned, but when are you going to do that, or who's going to do it? Clearly, you need the consultant to do it, and the consultant is not wandering around the hospital with nothing to do. He's either at a clinic, or he's in surgery, or he's in another hospital. So, it's easy to say that it should be done, but you really have to make sure it's resourced properly, both from a time point of view and an administration point of view.
I mean, is there a role for amongst a group of 5 or 6 surgeons in a specialty for there to be a rota, so that on Mondays David Moore does the telephone consultations and Deborah McNamara does them on Tuesdays, that kind of way?
Yeah, I certainly wouldn't be too prescriptive. I think if you could introduce the principle of it and let people see what works best in their unit. One of the things that would help is if people had kind of care pathways and there was an agreement that if it's a hip problem or a knee problem, that this is the path you follow. I think that would make it much easier. And, I think if it was introduced, it would make everything far more efficient, and it would certainly increase our PR value with patients in that they're seen much quicker. And I think the politicians and the HSE would be happy because the pressure comes off them. So there's a lot to be said for it, but it must be resourced.
Would it not be better to have an online questionnaire that had to be completed either by the referring GP or by the patient, him or herself, that would answer these questions rather than having the same questions asked time and time again by consultant staff?
One of the things there is the ENT referral system that Michael Walsh referred to, looking for a more nuanced referral coming from primary care so that sort of triage can happen automatically. With the volume of referrals that come in some specialties, it is very difficult for that to be a manual process. One nice paper presented at the Frere at the weekend showed some value in physician associates in being that first line virtual consultation. And if that's allied to care pathways, I think, I should say consultants aren't sitting around waiting for phone calls. It is difficult to staff this work by consultants, but if you can have another grade of permanent practitioner like physician associates who work to protocols and can select out the patients who really need to have either a face-to-face visit with a consultant or those who really need to be have a voice consultation with a consultant, I think that would be a useful way to triage.
Michael, do you have physician associates or clinical nurse practitioners who could help in that regard in head and neck ENT?
Yes, we have some physician associates in a few of the hospitals. They're very, very effective and very useful, and I would support their expansion. In our model of care, we we recommended the use of nurse specialists, either advanced nurse practitioners or clinical nurse specialists, to do a lot of this virtual work. It'll vary from specialty to specialty. Like if you have a high transference rate to surgery, you obviously have to see more and more patients face to face. But in our specialty, up to 14% of patients that are referred to outpatients are inappropriate referrals. So if you could even screen those out initially from attending, you'll be achieving a significant effect. And as David Moore said, this has to be resourced. It's not a by the way you do at the end of a clinic. It has to be properly structured and resourced. And combined with validated questionnaires, it can be effective.
Yeah, I'm getting the sense that there is a consensus that really it's something we should be working on and getting a triage at a nurse practitioner or physician associate level in the context of a clinical pathway for a defined problem. And that could reduce a lot of this potential increased workload, because once the genie gets out of the bottle and the Department of Health and HSE get it in their minds that every new patient should be triaged by phone, you know whose shoulders it's going to rest on. There are no questions coming in on chat. Is there anybody wants to raise their hand and ask a question? Well, if not, I have to thank our three speakers. I wish to really congratulate them for the amount of work they have done on behalf of Irish patients and the specialties from which they come. That we are really indebted to you for the commitment and the hard work. Next week, we're going out and about, and we will have contributions from Cork, Limerick, Galway and Belfast, telling us what's happening in the real world and not in the closeted confines of Dublin. By that time, by the way, Dublin is likely to be sealed off completely from the rest of the country. So with those happy thoughts, I thank everybody and thank Kieran and Pádraig and staff in Surgical Affairs for running the show so efficiently. So good night and keep safe. Thank you.